Good morning, chat. Today's case is going to focus around a 55-year-old female who comes into our clinic with a complaint of increased urinary frequency for the past week or so, and last couple of days she's having increased discomfort associated therein. So you as the resident have gone into the room, assessed this patient. She's otherwise healthy. She has no underlying medical conditions. She doesn't smoke. She doesn't drink. And you've come out, and the issue here becomes one of, can we just treat what seems to be a straightforward bladder infection, or do we have to actually get a urine sample? And the reason why this is relevant is because even here in Canada, as a physician, we have a scoring system for grading bladder infections that stipulates that if you have one of three criteria, so in this particular case, it can either be just the symptoms of frequency and the urinary discomfort when you go, as well as white cells when you do a urine dipstick or leukocytes, and nitrites when you do a urine dipstick. If you have just one of those, then there's a 33% chance of having a bladder infection. If you have all of them, it's a greater than 75% chance. So when you consider that, she has at least one of them, so should we at least treat? Moreover, the resident points out that now in Canada, pharmacists can just dispense antibiotics based on history, so all they would be getting is the actual history. And lots of areas of the world where people can just get antibiotics over the counter. So while the point is well taken, I think it behooves us to always sort of practice medicine as best we can. And I think we need objective proof that this is actually a bladder infection, so we want to get a urine sample. And plus, as this case is going to demonstrate, there's other conditions that will present very similarly. So we have this patient give us a sample, and sure enough, when the sample comes back, it shows no white cells whatsoever, no nitrates in her urine whatsoever, but she has 3+ glucose in her urine. So this shows a case why we want to be diligent, but it also takes in a direction as to where we go from the standpoint of diagnosing potential diabetes and how we go about that. So in this particular patient, we would need to then send them for a blood test to sort of establish where we're at with respect to diabetes. So if we do a blood test, a random blood test, which means she hasn't fasted, and that sugar level comes back at greater than 11.1, and that 11.1 is millimoles per liter. If that seems low to you, if you're used to higher sugar numbers, in Canada and the UK, we typically use this metric of the metric system. But in the United States, they use milligrams per deciliter. And to convert between the two of them, you would multiply by 18. So a 10 in our system would be 180 in the American system, a 20 is 360, and so on and so forth. And before you start to blame the Canadian system and using that damn metric system, just so you're aware, the other system is also metric. Milligrams per deciliter is also metric, and I have no idea why they use two different ones. Some turd muffin somewhere decided that, but we unfortunately have to deal with it. So getting back to this case, so if you have a random sugar that's greater than 11.1, or if they have a fasting sugar that's greater than 7, or if they have a hemoglobin A1C, which is the 3-month sugar, that's greater than 6.5%. And finally, if we send them for an oral glucose tolerance test, where they actually take a sugar drink and then 2 hours later they draw their blood work, if that level is greater than 11.1, then they would qualify for diabetes so long as they are also symptomatic. And now those symptoms can vary. So you couldn't have, in this particular case, like you're spilling sugar into the urine, or if you can have retinopathy changes or peripheral neuropathy, any one of those would qualify, and you'd only need one confirming test. However, let's assume that wasn't the case, so this patient isn't spilling sugar into her urine or having those other changes. You would need a second test to confirm the diagnosis. And that second test is there because it's important in some cases where you might just be at the cusp. So let's say your random sugar was 11.2 or your fasting sugar was 7.2. This could be falsely elevated by the last few days. So if you had a couple of birthday parties where people ate a lot of sugar, you might just be bumping up into diabetes, but you're not really quite there yet. Now, those patients might be pre-diabetic, and that's another case that we'll discuss, and the parameters are slightly different. But for this argument, we'll just sort of stipulate that we're working with specific diabetes. So now that we've actually made this diagnosis of diabetes, where do we go with things? And it's critically important that you explain to the patient what that significance is, because a lot of people may have no symptoms whatsoever, especially if you find it on a random sample. So you were doing blood work for some other reason and you stumbled into diabetes. And they're going to argue with you, why should I really change my lifestyle? Why should I take medication if it's actually necessary? And the studies actually show they won't be symptomatic till the sugars get quite a bit higher. So most studies agree that you won't start to feel any symptoms till it's at least greater than 11 millimoles per liter. But I found in theory, even when you get up to 12, 13, 14 for some people, they'll really have no symptoms. And so you have to explain to them the dangers of diabetes in and of itself. And from the standpoint of why these dangers develop in the first place, what they need to understand is that sugar is osmotically active. And what does that mean specifically? It means that as sugar molecules travel through the blood vessels, they pull fluid with it. So if you get enough sugar, you start pulling a lot of fluid. And anywhere in the body that works on a sieve-like mechanism, that's like a meshwork, and that's how it actually functions, or it gets nutrients to itself, those meshes will be blown apart with time as the sugar level is continually high and the sugar is pulling more fluid with it. And where are those specific areas? That's the back of the eye, that's the nerve endings and how they function. It's the kidney, it's the heart, it's blood vessel flow to the actual distal limbs. And this is why when you're diagnosed with diabetes, you're also technically a vasculopath. And what you need to explain to them in a non-threatening manner is that if you're diabetic, the risk of having a heart attack increases by 3 to 5 times, or 300 to 500% higher. If you actually are looking at stroke risk, if you're a male, that stroke risk increases by 2 to 3 times. If you're a female, that stroke risk increases by 2 to 5 times, or again, 200 to 500% higher. When you look at the risk of blindness, when you look at all diabetics, 5% will become clinically blind through the lifetime of having diabetes. And when you look at it from the standpoint of peripheral vascular flow, the risk of having toe gangrene and losing a toe increases by a factor of 30, or 30 times higher, which is massive. And the risk of losing your foot increases by 15 times. So these are numbers you should hold on to, again, not to scare patients, but to explain to them why it's critically important that we actually control these levels. Because what we want for them is to be as close to normal as possible so that these things never happen, so that they have quality of life. And what do those targets look like? We essentially need them to buy onto the concept that they want their sugars to be between 4 to 7 before they eat, between 5 to 10 after they eat, and we want their hemoglobin A1Cs, their 3-month sugars, to be less than 7 to have good control, less than 6.5% to have excellent control. Now, some people will even get less than 6, which is heading back to normal, and that's a nice guideline to have if people are otherwise healthy. However, I would warn you, if you're dealing with a brittle diabetic or with the elderly, you can get into risk with hypoglycemia and falls, and you have to be a little bit careful in that group. And so how do we monitor those sugars? You can talk to patients about getting systems where they pinprick themselves, which is annoying. Nicely now, they have new systems where you can just scan them. You put a sensor on your actual arm. Here in Canada, we have Dexcom 6 and now Dexcom 7, and there's also a Freestyle Libre system. All of those are very slick, and it allows you to actually scan it. And that's something you sort of encourage patients to, because the more information they have, the more they actually are invested in their actual care, and the more they can actually, monitor what's actually going on. So if you have that conversation with them, you get into these arguments about, well, where do we go with things now? And so as you preface this and you talk about heading into the treatment of diabetes, what you need to understand across a variety of areas is because it increases vasculopathy, we have to be looking at this from the standpoint of sugar control, from the standpoint of kidney protection, and from the standpoint of cardiac protection when it comes to the actual cholesterol levels. And we'll get to those in a minute. But first and foremost, we're going to talk about just general lifestyle, because if we can actually get the patient to be invested and control this through lifestyle modification, that is always the preference. And if you have a patient who's motivated, you have to work with them as much as possible. So what type of things can they be looking at? So from a lifestyles perspective, we're certainly going to be looking at dietary changes. And how impactful can those changes be? So there's numerous studies that have been around for decades now that look at what's the best we can expect from patients if they really do a wholesale change of their lifestyle. And almost all of those studies sort of work their way out to about a 25% change. So if you actually have a hemoglobin A1C of 10, the most we can reduce it through lifestyle is down to 7.5%. Now, is that a hard and fast rule? What I would tell you is absolutely is not. These studies are looking at population dynamics. So that's what they've found as a general average being the best possible. But if you have somebody who's motivated, if you have somebody who really wants to be investing in this and they're going to change their diet and lose weight and exercise, you can have massive changes in the area of 30, 40, 50%. People who have sugars of 15 or 16 in the American system, 300, 350, that type of thing. They can reverse it almost entirely if they really get behind this and get motivated. And they do this without medication. This is all lifestyle motivated sort of things. And so you want to be encouraging that as much as possible. However, the caveat I would give them is there is a window that is shrinking. So when we look at sugar metabolism and insulin production, this is a function of the pancreas. The pancreas has two cell types, the alpha cell and the beta cell. It's the beta cell that actually produces insulin. The alpha cell produces glucagon. Insulin is the molecule that allows us to take sugar from the actual vascular space and get it into the organ systems, predominantly the liver. So this is why with diabetes, there's usually an impairment in the production of insulin, or an insensitivity to insulin and how it functions. And this is what leads to this potential problem. However, the pancreas in the early stages is essentially giving us warning signs saying, hey, I'm really struggling. So if you hear that risk, if you hear that warning, I should say, you have a chance to reverse that and get the pancreas back online, and you may do well potentially forever or at least for years, which is what we want to do ideally. However, if you leave it for too long, if you have patients who sort of think, you know what, I'll take medication for a while or do a little bit of lifestyle change and I'll get on top of this in 5-6 years, you may very well be too late because the pancreas is going to sort of crap out or peter out completely, and then you'll be stuck having to take medications. So again, you have to get that message across so that they realize there's a time frame that's important here. So more specifically, what type of dietary things do we look at? And most diabetic agencies or groups will sort of have the same general approach when we look at macrobiotics specifically. So macrobiotics looks at carbohydrates, proteins, and fats and what they should be looking like. And generally, this is the most common sort of delineation we sort of get from those agencies. That from a carbohydrate perspective, we want to be taking between 40 to 65% of carbohydrates. From a protein perspective, we look at between 15 to 20%, and fats, they generally want less than 35%. Now, I would tell you in my experience, I don't mind those recommendations, but mine are slightly different. I usually want you on a carbohydrate level a little bit lower, so more like into the 40 to 45% range. The proteins, I generally try to encourage to be a little bit higher, so I usually look at 25 to 30% if that's possible. And fats, I generally want people to be lower as well. So I think less than 35% is pretty soft. I generally target less than 30, ideally less than 25% would be even better. However, recommendations beyond that, I generally agree with. So when they look at individual carbohydrates, they want you to have low glycemic carbs, which I agree with. And what are those low glycemic carbs? So that's looking at vegetable sources in general. Most fruits, some very sugary fruits don't qualify, like pineapple, watermelon, that doesn't sort of qualify. Grains and beans and those type of things, those are low glycemic carbohydrates, and that's what we want to be maximizing. And we obviously want to be getting away from high glycemic carbohydrates. And those are like cereals, white bread, white rice, essentially white sugar, white flour. That's where we get into trouble with certain things. So this is something that you'll want to be sort of processing through and encouraging them to move away from if they actually can. Then when we look at the protein aspect, if I'm pushing a 25 to 30% protein, they may not be able to get that from natural sources. So they sometimes supplement that with whey protein and those type of things. I don't mind that as long as they're not pairing that again with a high glycemic index carbohydrate, then I'm absolutely fine with that. And then when you're looking at fats, there's some hard and fast rules that apply here as well, because there's different types of fats. There's saturated fats, there's monounsaturated fats, there's polyunsaturated fats. So saturated fats are the ones that come from animal sources. So that's like beef, pork, chicken, and that includes eggs. And generally we want that to be less than 7%. And that I agree with. We should be getting away from saturated fats. And then polyunsaturated fats, the general recommendation is this should be less than 10%. And polyunsaturated fats are like fish sources, so a lot of salmon, tuna, some oils, walnuts, that sort of thing. And monounsaturated fats are like the avocados, most of the nuts, olives, olive oil, those sort of things. And that's what we want to be maximizing from that perspective. So that dietary aspect you do want to go over with them. And a lot of times I'll send patients to see a nutritionist or a dietitian because we just want to reinforce that as much as possible. Here in my city, we also have diabetic teaching courses that are available through public health. I imagine in your area that probably exists as well, and you should encourage that as well because the more educated they are, the better they will do for sure. And what about other lifestyle managements? So certainly if they're a smoker, we really have to emphasize the need to stop smoking. Again, like I said in other videos, people will do what they'll do and don't be dissuaded by that. Just encourage them as best they can. But as we talked about in other videos, smoking by itself increases your risk of heart disease by 200 to 400%. So if you pair that with diabetes, which increases it by 300 to 500%, you're now starting to get into really significant bad numbers. So smoking, we really want to be encouraging them to stop as much as possible. Alcohol is similar. Alcohol is not only hard on the liver and certain other organ systems, but alcohol is generally a carbohydrate. So if you're having large amounts of alcohol, you're going to be, from two fronts, it's going to be bad for you from a diabetic perspective. And then we look at exercise specifically. So should we be exercising if we're diabetic? And the answer is obviously absolutely we can. Generally, the recommendation is that you should be having 150 minutes of exercise per week. So most people divide that into 5 episodes of 30 minutes where they're going to be exercising. And in those 5 episodes, 2 of them should be resistance training. So doing some type of muscle lifting, muscle stimulation, I should say, with lifting. And there's numerous studies that shows that benefit from the standpoint of increasing insulin sensitization, from decreasing body weight, from decreasing blood pressure, those sort of things specifically. So you want to be encouraging that as much as possible. And you do have time with this, so very rarely does diabetes manifest itself as a really, really skyrocketed sugar level where you get an initial sugar over 20 or over 25. So again, in the American system, over 360 into the 400s. We just don't see that intuitively. You're going to see a lot of the low level diabetics. And so you don't really need to feel pressure towards medication, unless the hemoglobin A1C off the hop is greater than 7.5. And again, if you have somebody who's very motivated, even then you can sort of delay. But if it's less than that, you have time to give them to sort of get better with this. But let's say for the sake of argument, they've had no success or they have no intention of stopping smoking and they're really heavy set and you can just get a feel that this isn't going to be moving in that direction. How do we decide when to institute medication? Well, we're going to be looking at this from a number of different fronts, like I mentioned before, because it's not just the sugar that's the issue. And this is why this is going to be a global problem, which I'll get back to in a little bit. But looking purely at the sugars, so like I mentioned a little bit before, if their hemoglobin A1C is greater than 7.5%, we should be considering starting 1 anti-hyperglycemic. And if their hemoglobin A1C is greater than 9%, we should potentially be looking at 2. The nice thing nowadays is you have combination medications, so you can actually start 1 pill, but it may have 2 agents in it. And those agents will vary. In Canada, frontline is always metformin, which is a biguanide class medication. If I'm honest with you, that's mainly because it's been around the longest and it's cheap. So this is why that's available. There's lots of other classes of medication that function better. You can have insulin sensitizers, which are like your glyburide and your diamicron, gliclazide. You have insulin secretagogues. Those are insulin secretagogues. Insulin sensitizers are your Evangia and Actos, which are pioglitazone type medications. You have your GLP-1 agonists, you have your DPP-4 inhibitors, you have your SGLT2 inhibitors. There are really a whole bunch of different classes, and you will be familiar with some of these. The GLP-1 agonists are like Ozempic or semaglutide, so that's been taking the world by storm because it also affects weight gain. And it's really a very good medication for diabetes, but people are using it from a weight perspective, and that's certainly the subject of another discussion, and we'll get to that. But all I want to point out here is that you're potentially encouraging them to start 1 or 2 medications. And that's just looking at the sugar. Then we're going to be looking at the actual kidney protection and cardiac protection. So from a cardiac protection aspect, we start looking at cholesterol targets. And there are arguments to be said that just because they're diabetic, we should potentially be starting them on a cholesterol medication. All comers. Now, if you get into the weeds on that, there are certain indications that specifically say that that's when you want to be looking at that. And what are those specific indications? So generally, if you're a diabetic and you're over 40, you should consider having a conversation about starting a cholesterol medication, a statin. And statins are, again, like Lipitor or atorvastatin or Crestor or rosuvastatin, just to remind you what those classes are. Other ones is if they have clinical atherosclerosis, so they've actually had a mini stroke or an actual heart attack or some type of event that's similar, those patients should definitely be offered a statin. Or alternatively, if they actually have microangiopathic change, they're actually having already peripheral neuropathy, or the optometrist or ophthalmologist is saying they're having microretinopathy changes, those patients should certainly be offered it. And the last case that we look at is if they've actually had diabetes for a while, so they've had it for like 15 years and they're over 30, then they also should be offered it. If you're looking purely from a cholesterol perspective, that does become a standard as well. So if you're actually, let's say this particular patient is 55, if she had no risk, we tolerate bad cholesterol levels or LDL cholesterols, even north of 6. If they have modest risk factors, then we want it to be less than 3.5. But if they're actually diabetic, we want it to be less than 2, and new studies are showing less than 1.8. So you have all those things to consider in terms of offering that medication. So that's another medication that could potentially be offered. From renal protection perspective, we get into two different arguments. So again, there's lots of data that says that if you are just diabetic, regardless of any other circumstances and regardless of blood pressure targets, that you should be started on either an ACE inhibitor, which is an angiotensin converting enzyme inhibitor, or you should be started on an ARB, which is an angiotensin 2 receptor blocker. All stop off the hop, you should be started on those medications. Now, if you get into the weeds, it favors certain specific individuals again. So there's overlap with the statin argument as well. So if you have clinical atherosclerosis, you should have that conversation. If they have microangiopathic change, they should have that conversation. And then there's another subgroup, which is people who are over 55, so our patient would qualify, who also have other cardiovascular risks, and included in that risk is actually left ventricular hypertrophy. So you certainly would want to get an echocardiogram done and analyze these patients at some point in time because you don't want to be missing that parameter. But then we also look at the blood pressure itself. And as opposed to normal individuals where we tolerate a blood pressure of up to 140/90, in diabetics, we tolerate only a blood pressure of 130/80. So they for sure have to get less than that level. And if they weren't less than that level, again, you're having this conversation about introducing yet another medication, which is the ACE inhibitor or the ARB. And lately, in the last couple of years, there's been introduction of another entirely new class. And this is reserved for people who have chronic kidney disease, but are also type 2 diabetics. But we're finding that they're spilling a significant amount of albumin into their urine, or they're losing more protein, which shows that the kidney's not functioning well. Now, these patients still have a decent GFR. So their GFR is their glomerular filtration rate. So it's greater than 25, and they're not congestive heart failure patients. But the studies will show in those cases, we should start a class of drug called an MRA. And the MRAs are the mineralocorticoid receptor antagonists. The one that we're using in Canada is called finerenone, which is its chemical name. Its trade name is Kerendia. It's very good at what it does. When you look at the data, it's very protective for the kidney. It can reverse a lot of that damage. But consider I've just mentioned 5 different medications. So potentially we're starting 1 or 2 medications for their sugar, another medication for protection of their heart, which is the statin, another medication to protect their kidney, which is an ACE inhibitor or an ARB, and potentially an MRA as well. And that's a lot of medication. And if you take this patient as an example, so let's say she had all of these factors together. She came in and saw us on no medication whatsoever, otherwise entirely healthy. And we're going to potentially try to put her on 5 medications. That's not going to come over very well, and that can be very intimidating to the patient. And then you also have to worry about side effect potential as these medications intermix. I would always tell you, I think the better approach, especially when we're considering that we want to be emphasizing lifestyle change, if we absolutely have to start medication, I would target the sugars first and start 1 or 2 medications and see how the patients do. First, you're going to assess how they tolerate it and see what progress they make. And sometimes you'll be surprised when you actually start oral medications, they realize, hey, this is for real and I don't want to be taking these medications. And maybe that's the actual factor that pushes them towards getting healthier and getting out of this specific issue. However, if it's not the case and they're not getting better, then you're going to introduce at the visits long before you prescribe it the concept of protecting their heart and protecting their kidney. And then potentially you introduce those other medications slowly. But we do want to be maximizing their options in terms of preventing these potential complications, because that becomes the big issue. What I always tell patients is we really shouldn't be fearing death, because all of us are going to pass away from something at one point in time or another. The difficulty with diabetes is diabetes ends in debility. So you don't end up passing away, even though the most common cause of death in diabetics is cardiac, so you have heart attacks. The problem with diabetes is the last 10 years of your life is going to be met with some degree of significant debility. So you're either going to be blind, or you're going to be without a left lower limb, or you're going to be on dialysis, those sort of things. And you want to be emphasizing that as much as possible. And that's certainly something, like we mentioned in the preamble, when you're having the conversations with them, that you want to be emphasizing so that they understand that this is significant. So again, this is a lot of information to digest. I recognize this is a really large topic. We're going to be touching back on this again, because we'll probably be looking at each individual class of medication at one time or another. But just take this information for what it's worth, sort of digest some of these specific statistics and info points, and then we'll discuss another case at some other time. Take care.